Christine Schneider, the Visceral Voice.
Welcome to Season 2 of the Visceral Voice Podcast. I'm your host, Christine Schneider. Every week on this podcast, I talk with voice specialists, manual therapists, health specialists, psychotherapists, movement practitioners, and professional voice users about voice science, function, medication, movement, puberty and aging, and everything in between. I am on a quest, not only to become a better manual therapist, but also to learn everything I can about the living, breathing body and its intricate connection to the voice. This podcast documents the continuation of my learning and my experience as a professional singer, a nutritional consultant, and a manual therapist. Join me every week as we strive to provide current, knowledgeable, creative, and compassionate information to help restore, regain, and create happiness and success on your vocal journey. I was very excited to have this conversation with Dr. Paul Kwak. I am not going to read his bio because he does go into telling his own journey into becoming a laryngologist, and it is fascinating, so I don't want to give anything away. Paul and I were having so much fun during this conversation. It was one of those conversations that could have gone on the rest of the day. So I'm really, really excited about having you hear this episode full of wonderful information. I first heard about Dr. Paul Kwak from several of my colleagues and my clients, definitely around the aspect that he truly understands the life of a performer, which a lot of people, of course, very much value, but also feel that that's rare in the medical community. So he is not only a doctor with incredible bedside manner, as you would say, but he also seems to be a rising star in the field of laryngology. I am really stoked to bring you my conversation with Dr. Paul Kwak. Hi, Paul. Welcome to the podcast.
Hi, Christine. Thanks so much for having me. I'm so delighted to be here. I have so many friends and colleagues who listen to you, so it's an honor and a pleasure to be here.
Oh, thank you so much. I am really, really excited that you are willing to do this podcast episode today talking about voice pathologies and voice procedures. So thank you so much for being here.
Totally. Yeah, my pleasure.
So I have heard a rumor that you are also a pianist. Is that true?
It's true. I tend to use the past tense verb. I started as a pianist, and that's how I kind of got into this. And I am a pianist, for better or for worse.
So how did you go from being a pianist into becoming an otolaryngologist?
Yeah, it's a windy journey, but it's been a great and immensely fulfilling one that came together kind of at the very end. So I actually started just as a regular undergrad student studying history. I always played the piano, and I love the piano. And when I was finishing up college, medicine was always in the background, but I kind of had this visceral sense that I didn't want to go straight into medical school. I felt like there was just too much else to explore. So I actually applied to a couple of grad schools, one in government and public policy and one in music. And I was admitted to the Juilliard School for Graduate program, a master's program in collaborative piano, which is a subdivision of, sort of the general piano division. It focuses on, as it suggests, collaboration. So there was a track at that time that was instrumental music, and I had played a lot of chamber music, and I didn't know much about the voice at that time. So I thought, well, I'm going to try the vocal accompaniment track. And so I did that. I think before I did that, I wouldn't have called myself an opera person or a song person. I mean, I loved listening to voices, but I just didn't know much about it. I sort of caught the bug there. I mean, I just became very enamored of singing and singers. And one of the things that I loved doing was just playing voice lessons and sitting in studios and listening to teachers talk to their students about how to train the voice. It was 2 great years of my life, but toward the end, I just thought I knew that I wasn't probably meant to spend my days in the basement of an opera house. So I started thinking again about medicine. And my piano teacher, one of my great heroes of my life, Margot Garrett, was very good friends with Steven Zeitels, who is the voice surgeon that's become very renowned for operating on Adele and Sam Smith and Bono, one of the major laryngeal surgeons of our time. And she said, you should spend some time with him in his clinic. And so I did. I took the train from New York to Boston, and I met Dr. Zeitels first. And that's kind of when the light went on about how these various strands of my life might come together. And that's kind of the seedling of it. And then I went to medical school, and then I did residency in Houston at Baylor and MD Anderson. And then I ended up doing my laryngeal surgery fellowship with Dr. Zeitels in 2015. 10 years later, here we are, and I'm a laryngologist in New York. So it's, in those early days, it was not always so clear how this would turn out, but it's been the best kind of intersection of the things that I love in life. Yeah.
Well, something that I often hear about you, because you are the word on the street right now of the otolaryngologist
That's really sweet.
in New York. And I think that part of that, at least from the people that I'm hearing from, they really feel like you understand them in a way that some of the other doctors don't. And part of that is how you're communicating with them, or what we would say like as a bedside manner. So when you're dealing with someone, how do you go about talking to them about having some kind of pathology from a compassionate, sympathetic space?
Yeah. Well, it's so nice to hear that, because I think that one of the things that helps me get up and do this every day is that I have a heart for singers. And I think that is rooted in those days at Juilliard, in the studios, watching singers try to figure this out, watching them in their practice rooms, understanding the struggles, the frustrations, not just sort of technically and vocally, but just generally with life. It's a hard career. Your success is, first of all, based in the coordination of this organ, this set of organs inside your body that is both governed by voluntary and involuntary forces that changes from day to day. And then ultimately the product of that is judged by people who have different opinions about it. I admire the courage of singers who get up every day and go to auditions and get on stage. I remember once Margot put me in front of the piano. She was like, you need to understand what it feels like to stand in front of that piano and look out at the audience and sing. Because we as pianists we kind of have our side to you. But singers are facing forward. And so I lived a lot with that and continue to live with just how immense the demands are of singers, both physically and psychologically and emotionally. And so I'm very aware of that every time I enter the clinic room and create a space for us to have a discussion about what's going on at the level of the vocal folds and whether or not there's pathology. So I think that that's a sort of thing that's hard to acquire in medical training, right? And in fact, a lot of medical training is, especially surgical training, part of the psychology is that you sort of disembody the anatomy from the person. When you're in an operating room and you have to make an incision on a patient's neck, I think it defeats you if you're too emotionally attached. So some of the endeavor of surgical training is learning a detachment. So being able to maintain a sense of humanity while still being a surgeon, I think is very difficult. I think about that a lot. And I also think that part of my training that has really helped me is that I have quite a bit of vocabulary that is not always readily available to laryngologists who train in traditional ways. So I understand issues of Fach and genre and style and subtle abnormalities in transition zones like the passaggio. And I understand and can really resonate with smaller, subtler issues in the singing voice. And I think that that's essential in the care of a performing voice, I think is subtlety and attention to nuance. That's a little bit of far field from the origin of your question about bedside manner, but I think that when you are pressed to talk with a patient about pathology in the vocal fold and that patient is a performer, I think it's absolutely essential to have empathy and compassion for the significance of that to that singer. I think it's much different if you're a guy who sits behind a desk and puts data into a computer and doesn't use his voice all day and you have a polyp versus a singer who has a polyp. So I really make a lot of effort to hold that space for singers.
Yes, and that is certainly being noticed by the community. So thank you so much for holding that space.
Absolutely.
Before we go on to talk about pathologies, can you just
Yes.
talk to us about the difference between an ENT and a laryngologist for those who may not know?
Yeah, sure. So ENT, of course, as most people probably know, stands for ear, nose, and throat doctor. And the medical word for that is otolaryngologist. Some people call us otorhinolaryngologist, which is just, the Latin derivations of ear, nose, and throat doctor. So in the past, I don't know, 10, 20 years, increasingly we have specialized even within otolaryngology or ENT into these subspecialties. So ear, nose, and throat. So I have colleagues who are neurotologists, which are basically ear specialists. I have colleagues who are rhinologists or sinus surgeons who are specialized in the nose or sinuses. One branch further has become head and neck surgery, which is surgeons who do a lot of surgery to operate on benign or malignant processes in the head and neck. And I'm a laryngologist. And so I, I tell people that I'm just the T part of the ENT. And that's what we do. And I think in the last, like I said, 10 to 15 years, we have grown up as a more subspecialty. I mean, the American Laryngological Association goes hundreds of years back, but it's increasingly in the past decade or so that it's really become an important part of the care of the performing voice. I think that's because now to be a laryngologist, we accept that there is that extra year of training after residency. So a typical ENT residency is 5 years. That last year of training that I did with Dr. Zeitels, we call a fellowship, and it's a fellowship in laryngology. So laryngology encompasses things like voice, airway, and swallowing, basically anything related to the larynx or the structures in and around it. A certain number of laryngologists will further specialize in voice and performing voice. And often that has a lot to do with where you are. So in a city like New York, there are a number of excellent laryngologists in the city, and we all have sort of niche specialties. But some in less densely populated cities, laryngologists will do a broader mix of things like voice, airway, and swallowing. So my practice happens to be predominantly performing voice, and I think that's kind of an outgrowth of my interests and my affinities, but also where I am. But relevantly to your listeners, I think performers who are interested in establishing care do very well to really establish care with a laryngologist, because I think there is enough now that people benefit from having care from a specialist, a subspecialist.
So it would be kind of hard to say what the percentage of surgeries performed on the vocal folds would be, because that would kind of vary between state or city.
Totally.
So in the city, in New York City, would you know kind of more of the percentage that you as a laryngologist would do a surgery on vocal folds versus an ENT?
Yeah, I would guess, I don't have any actual demographic data on this, but I would guess in New York City, most of vocal fold surgery is done by laryngologists because people have access to them. There are more centers that do it, and we do subspecialize. So I would guess a majority, probably 60, 70, even upwards of 80%.
Would most ENTs in the city then refer their patients to a laryngologist for a vocal pathology?
Yeah, tend to. So we do see there are a number of private practitioners who are general ENTs, or in bigger groups where there may not be a fellowship trained laryngologist, and we see patients from those groups who have been diagnosed with some sort of vocal pathology. I think it's prudent to have someone operate on that who does it all the time. So we do get referrals from our colleagues, and also just from general practitioners throughout the city. For sure.
Great. Okay, so moving on to voice pathologies.
Yeah.
Okay, so we're going to talk about the pathology, possible symptoms, causes, and possible treatments.
Yeah, I think that's great. So I guess before we get super granular, I think maybe I'll lay out just a bit of a framework, because many of these are fairly similar to each other, actually. So nodules, polyps, and cysts, in some way, I lump into the same kind of category. We call them phonotraumatic lesions.
Right.
And that means lesions of the vocal fold, masses, lesions that arise in the setting of what we believe is phonotrauma, trauma created by the creation of sound at the level of the vocal folds. And just to go a little bit into the weeds of it, without getting too super technical, but I think it's helpful to understand that the reason we think these arise is there are blood vessels in the middle layer of the vocal fold called the lamina propria, and those blood vessels feed and nourish the vocal folds. And what we think at a basic level happens is that in the course of a vocal event or a series of vocal events, there's some disruption to those blood vessels, and there's a small to large injury that can happen where either blood spills into the core or there's just a micro tear that then induces a wound healing response. These lesions are ultimately the body's effort to sort of heal smaller phonotraumas. So we think that polyps are a great example of that, arising from a hemorrhagic or a blood-induced event, and nodules similarly. So I think that's helpful as a starting point for the discussion about what pathology is.
Yeah.
And it's interesting because when we're in medical school, we learn classically anatomy and pathology. And in traditional medical schools, it would be the first year you learned all normal anatomy, and in the second year you learned pathology, meaning basically bad stuff that can happen to the body.
Mm-hmm.
And so it's interesting because I've come to think about pathology and the ways that term becomes so pejorative and negative and can therefore, especially in our voice world, induce a lot of fear and anxiety and shame and stigma around these pathologies.
Mm-hmm.
Pathology to us is just a way to characterize tissue as abnormal. But what we see time and time again in elite vocal performers is that many of them actually have chronic pathology.
Mm-hmm.
And they're singers and performers on the most elite stages in New York City and around the world, performing at the highest levels possible. And they have what you would look in a textbook and look up as pathology on their vocal folds. But the mechanics are so refined and the function is so advanced that the pathology is only one component of their voice. So, and we'll come sort of back again to that recurring theme, but I lead with that because I think it's a really important part of the discussion of pathology is decoupling the kind of shame that arises from the thought that you're doing something wrong in order to have induced the pathology.
Yeah.
We see phonotrauma in very healthy singers and very elite singers. So the corollary to that is we see a lot of young singers who have no idea how to use their voices and their vocal cords are pristine, right? So it's not a one-to-one correlation between pathology, bad voice, normal anatomy, good voice, right? It's much more complex and nuanced in the discussion of vocal cord pathology.
Thank you so much for saying all of that. If
Yeah.
you hear nothing else of this podcast episode, exactly what Paul just said, please hear that. Thank you. That was so beautifully stated.
Thanks for inviting the discussion, because I think what I love about this podcast and the durability of it and the fact that the information has some legs is that it is a message that increasingly more centers are trying to get out, because there is this kind of artificial divide. Like when you come into the doctor, I'm a doctor, and so you expect a diagnosis, and the diagnosis is either bad or good, and then there's a treatment plan, but it's not so straightforward in the voice. And so I'm more than happy to talk about it. I'm happy to talk about the actual pathologies now, and we'll do that. But overwhelmingly, that is my kind of soapbox. One of my sort of passions and missions in this life is to work to change the culture with colleagues like you and eliminate the kind of fear and shame and stigma around vocal pathology.
Yeah.
And really all you have to do is hang out with us for a day in our office, any of our offices in New York City, and you see all these performers who have stuff on their vocal cords. So I'm happy to start talking a little bit more nuts and bolts about that now. So We'll get into the pathology that you had sort of mentioned, symptoms. So I tend to say, like as a rule of thumb, that when there is something on the vocal folds, you tend to hear it before you feel it. When you're noticing a sort of persistent change in the quality of your sound at the level of the larynx, which can be a little bit tricky to disentangle, right? I mean, so like, for example, if you have a head cold, you sound different, but that's more of a resonance issue. When your voice teacher, your voice coach, your speech language pathologist really start to notice a change in the acoustic signal of your sound, that's when we start to think that there may be something on the vocal cords, as opposed to sensations. So like pain, discomfort tends to be more above the vocal cords, where we call this the supraglottis. It can be related to tension or strain of the muscles of the larynx and the ligaments and the spaces in between the bones and cartilages of the larynx. It's not 100% perfect, but that is often a helpful way for people to start kind of understanding what's going on with them.
Yeah.
If you're feeling something, if it's pain, discomfort, tends more to be everything but the vocal cords. And when you're hearing something, tends to be more vocal cords. Now, if you have a giant polyp, if you have a giant hemorrhage, that will cause you discomfort, but generally that's a pretty reasonable distinction. So with nodules, polyps, cysts, usually the first presenting sign or symptom of that is a change in the quality of the sound.
Mm-hmm.
Sulcus, similarly, sulcus vocalis, just to define that a little bit, is what we think of as a scar, generally a linear scar band on the vibratory surfaces of the vocal folds. Difficult problem to solve, but all of these pathologies, and I'm happy to sort of go into each one as you see fit, start fundamentally with a change in the sound of the voice.
Yeah. And so with sulcus, a sulcus could be congenital.
That's right. When we go to fall voice conferences, I mean, there are like hours of panels on sulcus. Sulcus can be congenital, you can be born with it. Perhaps more commonly, it arises from just chronic phonotrauma. Your vocal folds are colliding. I love talking to young singers about how A440, concert A, means that when you sing A440, your vocal folds are vibrating, colliding with each other 440 times a second.
That's so amazing.
It's amazing. And think of, multiplying that times one phrase, times an aria, times multiple arias, times an opera, a show. So it's an immense amount of wear and tear on the tissue. And part of what we are really trying to think about, I think the next frontier in voice, is understanding, why do certain people get sulcus? Why do certain people get nodules? Why do certain people get polyps? Because at some level, we're all using our voices every day, right? And not everyone develops this nodule or polyp. So there are a couple of concepts in here that I think are worth elucidating a bit further. First of all, to take a step back to that A440 concept and thinking about the amount of force and energy that passes through the larynx during any given kind of phonatory event. We talk to singers a lot about the concept of vocal athleticism. And this is a concept that's becoming more and more, there's more light on this and more people are adopting this. But singers in training are absolutely equivalent to sports athletes in training. And that's not just something that we say that's a nice way to make singers feel better about how hard they're working. It's actually, if you look at the force and energy passing through the larynx when one sings, it's immense. And I think that helps animate and shine some light on the discussion about pathology, right? Because if singers are indeed training as hard as football players and hockey players, when a football player busts his ACL, no one says, oh, he was running too hard, or he's a bad athlete.
Right.
It's a little imperfect. Football is a contact sport, but injury, it is a not unexpected outcome of training. And so similarly, when a singer has an injury that results in a pathology, I think it's important that we start to help them think about it the same way.
Right.
And then finally, and then we'll circle back, but I think these two concepts have arisen from this discussion in a really helpful way. I happen to work with a lot of the trainers at Rumble Boxing. I mean, talk about vocal athletes. And we see a lot of fitness instructors in our practice too.
Right.
But they have an immense amount of demand and tax of their vocal folds. I happen to get to know one of them named Rob Sulaber. He's actually become my personal trainer, one of the greatest trainers in America, an elite athlete, but also a vocal athlete. And he posted something recently, which I think is just so interesting in the context of vocal cord pathology, which is the idea of body privilege. And that Rob has a great body, and he looks like he works out 10 hours a day nonstop. He works out a lot, but he's got abs for days. Now, I could do like 800 sit-ups a day and never have Rob's abs. Why is that, right? It's because there's some intersection of anatomy, the sort of cellular makeup of his body, and his response to sort of repair an injury that creates his specific kind of body type, creates my specific body type, right? So in the same way, I think about this a lot in terms of the voice. When people come in and they're like, well, I do the same things, these young students who come in, I do the same things that my classmates do. Why did I get a polyp? Why did I hemorrhage? Why do I have sulcus? And I think ultimately we will discover that it has to do with the way the wound healing forces in the body respond to phonotrauma.
Mm-hmm.
If everyone were the same, first of all, choruses and shows would be so much less interesting, but my job would be much simpler, right?
Mm-hmm.
And so I think a lot of what we're starting to think about in terms of pathology on the vocal cords has to do with individual responses to wound healing in the context of individual vocal demands, style, genre, and it all adds. It's a really complex discussion to have with singers who have these things.
Right. Well, and then add to that anything that might be going on in your personal life as far as a loss of a family member or a divorce
Oh,
or
that's
something's
huge.
happening psychologically, it will change your wound healing.
I'm so glad you said that because sometimes people think that that's a little bit of a woo-woo thing, like it's all in your head.
Mm.
Well, I like to say actually that all voice is psychosomatic.
Mm.
At some level, it's all governed by brain and brainstem. And the same centers that govern emotion and psyche, very close to the same, the centers in the brain that regulate motion of the larynx. And, when actors and singers use color in their sound, what does that mean? At some level, it's emotion, psyche driving the
Mm-hmm.
mechanics of the larynx. So, of course, and it's no coincidence that we see so many voice issues arise in periods of stress or loss or anxiety. And those issues certainly are just as significant as actually having, something on the vocal folds. So
Right.
I fully agree with that.
Great. Okay, so if we're talking about nodules
Yeah.
and polyps, so
Yep.
nodules are kind of like calluses, polyps are kind of like blisters.
Yeah, that's not a bad way to think about it. So classically, we think of nodules as bilateral, meaning they tend to be, you see one on each cord. People kind of go back and forth and debate this, but we think probably what happens is that one arises on one cord and you get reactive kind of swelling and wound healing on the other cord, and so you get two. When you read the literature and the textbooks, classically nodules are bilateral, whereas polyps tend to be unilateral, meaning just on one cord.
Mm-hmm.
It's an imperfect division, but yes, and nodules tend to be, again, and I'm using sort of hedging language because there's a lot of disagreement actually about like what they are, how they look, but sort of textbook definition, nodules are generally denser, somewhat firmer, and kind of in the middle of the vocal fold, and again on both sides. Polyps tend to be a bit softer. They can be bigger or smaller. They tend to be what we call hemorrhagic, meaning kind of full of old blood, kind of wound healing products. They look more kind of like the center of a jelly donut as opposed to like calluses. So I think callus versus blister is not a bad, I think that's actually a really reasonable way to kind of visualize in your mind's eye the difference between the two.
And then what would be the treatments for each of those?
Yeah. So I guess let's start with nodules because I think it's a good way to animate and think about all vocal fold pathology. Typically with nodules, we start with a concerted session of good voice therapy for a couple reasons. One, we think that the behaviors and the functional and technical issues that led to the formation of the nodules in the first place benefit from being addressed, even if surgery is considered. Because if you just operate on them and you let the singer go back to doing exactly what he or she was doing before, we think there's likely to just be reformation of those nodules. So surgery, at least for me, surgery almost always happens in the context of functional and behavioral support. So preoperative and postoperative voice therapy. That's also true for polyps. I think it's important, much more important for nodules because they tend to be more long-term chronic phonotraumatic lesions, whereas polyps can arise in a somewhat shorter span of time. And the other thing about polyps is that I tend to think of them as more favorable surgical lesions because they tend to grow above the surface, above the epithelium. The big issue in vocal cord surgery is that you do everything you can to preserve the vibratory layers underneath the epithelium of the vocal fold. Because once you injure or affect or scar those layers, you're in a way kind of done, because that is kind of one of the next frontiers in voice science, is figuring out how to keep that middle vibratory layer, the lamina propria, soft, supple, and vibrating. So with polyps, like I said, you tend to have a much larger margin. I mean, we're still talking on the order of millimeters, but you feel much more confident that you can excise that safely, create a more normal edge of the vocal fold, and make a much more sort of dramatic improvement with the surgery. Whereas with nodules, you have to be really careful, and the gains can be smaller and the risks are higher.
Mm-hmm.
So generally, vocal cord pathology for me is always a combination of behavioral and functional modification coupled to sometimes a surgical intervention.
Right. Sometimes.
Sometimes, that's right.
Yeah. And with a polyp, is it true that you could get a polyp from coughing, sneezing?
Yeah, we have seen that. Yeah, for sure. It's admittedly rarer, but yeah. And again, it goes back to why we think they form. It's some sort of hemorrhagic or disruptive event in that middle layer of the vocal fold. So yes, coughing and sneezing can be incredibly traumatic to the vocal folds. And theoretically, with one event like that, you can have a little hemorrhage that creates a polyp.
Mm-hmm.
It's a little bit unusual. They usually arise in the setting of somewhat more chronic phonotrauma, but yeah, we've seen it happen for sure.
Yeah. So in the discussion of cysts,
Yes.
I know, or at least I think there might be some controversy
Yeah.
over like a pseudocyst. Some people call it pseudocyst, some people call
Yes.
it cyst. Are there other names for it?
It's a great question. It's a great discussion to have. So first of all, just generally speaking, a cyst is a fluid-filled sac. That's all it is. It's a little ball of epithelium, which is skin, that the body has walled off, and there's fluid inside it. You can get them on your hand, but you can get them anywhere. So there are a couple different kinds of cysts that arise in the vocal folds. First of all, there are congenital cysts, so you're born with them, and those tend to be bilateral, meaning one on each vocal fold, and they tend to be more in the substance of the cord, like in the middle of the vocal fold. Those often don't have much significance on the voice because they're not disrupting the edge, they're just sort of in the vocal cord. There are cysts that can arise through phonotrauma, and I guess what we think happens is that there's a little bit of disruption to the edge of the epithelium of the vocal fold that kind of folds back on itself and then creates a cavity in which the fluid can form, and it does create kind of a smooth lump on the medial edge of the vocal fold. I just operated on one yesterday, and those do create, when you're going to speak, they create a disruption in the closure and the vibration of the vocal folds.
Mm-hmm.
So those are actual cysts. They're walled off, fluid-filled sacs. And they respond very well to surgery. It's a difficult surgery to do, but patients tend to do really well when they're removed. So pseudocyst is a term that I think I can attribute to Dr. Sulika at Weill Cornell. And it was meant to describe a phonotraumatic lesion on the mid-third of the vocal fold.
Mm-hmm.
And it would be great to have some visuals with it, but it is not, in fact, an actual walled-off cavity of fluid, which is why I think he calls it a pseudocyst. But it's a common lesion that we see, actually, in performers. So I believe that it's the same thing that people describe when they're looking at what other people might call pre-nodules. It's probably an early phonotraumatic lesion that's still soft, relatively translucent, but does create a contour deformity on one of the edges of the vocal folds. And so it has, if you're just looking with a laryngoscope in the clinic, it has kind of the appearance of a cyst, but it's not, in fact, an actual cyst.
Mm-hmm.
And so that is what is typically meant by and described by pseudocysts. And it's interesting, we do see a fair amount of those pseudocysts or pre-nodules in performers at all degrees of experience and level. And I think the reason that is that it's kind of an early sign of phonotrauma, and just the same way that we favor our right hand or left hand when throwing, our right foot or left foot when kicking in soccer. I think there's probably some unequal distribution of forces during any sort of vocal event, and particularly when you're using your voice a lot and training, you may get differential or preferential sort of strain or trauma on one vocal fold that starts to manifest in this kind of wound healing reaction on one side. And when you catch it early, it hasn't, as we say, sort of hardened, quote unquote, into a nodule, but it's what some people, again, call a pre-nodule, what others call a pseudocyst.
Mm-hmm.
And I think the dirty little secret, which isn't such a dirty little secret anymore. In fact, our great colleague Christine Estes just gave a great panel on this at our Fall Voice Conference, was it's a way to get around kind of the name game, because there is so much fear and anxiety and stigma about nodules. I mean, it's wild how that drives people into this state of fear just to say the word nodule. So pseudocyst, pre-nodule, these are terms that I think we've all started to try to use to soften the blow of the diagnosis of a pathology. Because pseudocyst doesn't sound nearly as bad as nodule, right? Neither does pre-nodule. People say, oh, I just have pre-nodules, I'm fine. So I think that's a lot of what pseudocyst and pre-nodule is about.
Yeah. Okay. So going on to dysphonia.
Yes.
Let's start with muscle tension dysphonia.
Sure. Big category. I mean,
it's such a big category, and it's quite general.
It is. And in some ways, I think it's a term that captures a lot of what's going on, but it's also it can be a bit of a garbage can diagnosis. So the concept of muscle tension dysphonia is that dysphonia just refers to, a disturbance in the sound, dysphonia. And muscle tension dysphonia essentially is attempting to describe that change in the sound arises from some issue with the muscle coordination of the larynx. And we tend to think it's a hyperfunction, too much muscle in a way. So you're squeezing, or it's an inefficient coordination of breath to oscillation of the vocal folds. There's something about the biomechanics that disrupts the sound. Now, we often will talk about the difference between primary and secondary muscle tension dysphonia, and I think that's an illustrative distinction, so primary muscle tension dysphonia tends to be seen in patients with quote-unquote normal vocal folds, where there's no actual discernible pathology of the vocal folds, and therefore the dysphonia arises primarily from muscle tension or muscle discoordination. It's essentially a coordination behavioral issue. Secondary muscle tension dysphonia refers to the fact that, for example, people with very large polyps or even very small polyps can develop inefficiencies in the mechanics of the larynx because you're trying to compensate for that polyp there, right? So your brain, even if you're not conscious of it, you're sensing that there's something wrong with the way that the vocal cords are closing and vibrating. And so you're working harder to try to compensate for it. And so you can get some tension and discoordination around an actual vocal fold lesion. And it speaks to the interplay between anatomy and function here, right? That it's not always one or the other, and that, in fact, it's sort of chicken and egg. Is it that you have developed a muscle tension dysphonia kind of pattern because you have something on the vocal cords? Or did you get something on the vocal folds because of the biomechanics of your larynx and the way that your vocal cords vibrate during any phonatory cycle? So it's a big topic, but in a nutshell, that's what MTD or muscle tension dysphonia refers to. And primarily we treat that with voice therapy.
Yeah, and manual therapy.
Yes, thank you for pointing that out. Because I know I'm preaching to the choir, but that is one thing that often is overlooked, right? That it's not just sort of voice and breathing, but there actually can be quite a bit of literal tension in the fascia and the ligaments around the larynx, to which actually people respond immensely well with myofascial release, laryngeal manipulation. So absolutely.
Yeah. And we have a whole podcast episode coming out with Jeannie Goffey-Finn on MTD.
Awesome.
So spasmodic dysphonia.
Also topic for many conferences and many hours.
Yeah.
Essentially, that refers to a disturbance in the voice that's caused by spasms of the muscles of the larynx. And there are generally two types. One relates to what we call AD ductor spasmodic dysphonia, which is primarily the muscles that bring the vocal cords together, so primarily the thyroarytenoid muscle, and AB ductor spasmodic dysphonia, which refers to the muscles that open the vocal cords. I wish I had a sound clip, but Diane Rehm of NPR was a very public SD patient, and she would always talk about how her listeners would tell her when it was time for a Botox injection, because you can really hear it. It's a very tight, often pressed and strained voice, because you're trying to control these spasms that are happening in the voice box that contribute to kind of frequent voice breaks. The voice is often very halted and interrupted. It's, again, thought to be a spasm of those muscles of the larynx. There's a lot of fascinating research going in spasmodic dysphonia. And what we're starting to discover and inquiring about is that it's rooted primarily in brain and brainstem function. And so a lot of the upcoming treatments, I think, are likely to target those centers. Right now, the best treatment we have for it is Botox injections. And so patients who have spasmodic dysphonia often will come in every 3, 4, sometimes 6 months, and we do an injection in the office directly into their vocal cords of Botox, and that helps to settle down those spasms.
Yeah. So spasmodic dysphonia is really more a neurological condition.
Absolutely. Spasmodic dysphonia, yes, indeed, is a neurologic. We dump it in our box of neurolaryngological conditions.
Yeah. And so what about bowing of the vocal cords?
Yeah. Bowing is a descriptor that we use to characterize things we see. So when you look at the vocal folds and you see that they're bowed, so I don't know how many of you listening have seen vocal cords, but they generally tend to have, we think of vocal cords as having smooth, straight edges, and sometimes even a little bit convex. So when the vocal folds have a concave appearance, we call that bowing, and the consequence of it, or the significance of it, is that when you phonate and attempt to bring the vocal cords together, because they're concave, they don't come all the way together, and so there's a little bit of gap between them, and that can create inefficiencies in the voice, can create a hoarse, breathy voice, and sometimes, again, in that secondary reactive muscle tension, it can create kind of a strained voice. There are kind of two primary reasons, I think, that people will have bowing of the vocal cords. One is sulcus, which we mentioned, and that kind of sticks the epithelium to the lamina propria or the ligament underneath the surface and creates a bowed appearance. The other thing can be what we call vocal fold atrophy. So this typically is seen in older patients, but there are some younger patients that demonstrate some features of this. But what we think is either that the muscle thins, that's sort of a more classic definition of atrophy, is that there's wasting of the muscle. But also in older voice patients, there can be some loss of the lamina propria in the middle. And so the tissue essentially becomes thinner and has a bowed appearance on exam. So bowing is a descriptor, but it's not a diagnosis.
Yeah, great. And then another big topic, paresis versus paralysis.
Yeah. So there's been a controversy about this. I mean, so let's start with paralysis because I think it's kind of the more straightforward one. Vocal fold paralysis can happen for at least 100 different reasons. It is when one or both of the recurrent laryngeal nerve stops working. The recurrent laryngeal nerve is the primary motor nerve on each side of the larynx. And so it comes down from the brainstem, loops into the chest, goes under the aorta on the left, and goes under the subclavian artery on the right, and comes up alongside the trachea and plugs into the larynx on either side. So anywhere from the brainstem down into the chest, all along the trachea, if you have a tumor, if you have compression, if you have surgery, anything can compromise the nerve transmission in that recurrent laryngeal nerve, and that can cause a paralysis, by which we mean essentially total loss of function of that vocal fold and often that side of the larynx. So that is not a subtle thing. When that happens, you lose function in that side of the larynx. So yeah, when you lose it on one side, it tends to be characterized with a very weak, breathy voice. You can imagine if one vocal fold is just not coming to the middle, you leak a lot of air between those vocal cords as you're trying to speak. People get very winded when they're trying to speak. When both go out, that can be more of an airway issue because essentially they're stuck near the middle, and so it narrows the patient's airway. So paralysis, there are a lot of ways that can present, but the exam findings tend to be somewhat clearer and less subjective. The reason I say that is because paresis is a term that has emerged somewhat recently, and a lot of that has been driven by our colleagues at Weill Cornell. Dr. Sulika has written a lot on paresis. I would just say there is some disagreement about that concept, about paresis. Basically, paresis implies diminished motion of one or both vocal folds. not a full flaccid paralysis, but just a diminished motion. The implication being that this can create problems like polyps or pathology because there's differential kind of strain or use of the muscles on one or both sides of the larynx that predisposes, that vocal fold to greater phototrauma, giving rise to polyps. I guess I'll just leave that because that's a big discussion and it's somewhat controversial. And I will say I subscribe less to the idea that vocal athletes commonly have paresis. It doesn't make a lot of sense to me, but that is that concept. It's just sort of an incomplete paralysis.
So I have had several clients that seem to have had a full recovery from a paralysis.
Yeah, and it's not unreasonable. One category of vocal fold paralysis, the things that can cause it, is what we call idiopathic. And just in the same way that Bell's palsy is, we think, triggered by some sort of viral process, a viral infection of the motor nerve of the face. Similarly, we think that there can be an idiopathic, presumably virally mediated infection of the recurrent laryngeal nerve that just resolves over time. So it's like, the nerve hasn't been disrupted, it hasn't been cut, but it's sort of sick and it recovers. So it is possible, for sure.
And the recurrent laryngeal nerve is off of the vagus nerve.
That's right. That's
So
exactly right.
would that result in anything with the vagus nerve?
It's a great question. So if it is, as we say, a high vagal injury, meaning we think that the infection or trauma or injury has occurred above where the recurrent laryngeal nerve splits, there certainly can be more symptoms of that. In fact, the vagus nerve is an incredibly important nerve in motor function with swallowing. So patients who have high vagal injuries can have real issues with passage of food and liquids. And the swallowing can be very discoordinated. If it's just the recurrent laryngeal nerve, it typically manifests only in voice. But yeah, there can be a wide range of symptoms.
Yeah.
Yeah.
Okay, so moving on to procedures,
Yeah.
just a few that I know about.
Yes.
Let's start with a thyroplasty.
Yeah. So thyroplasty refers to, any plasty refers to a change in the shape of the organ that you're considering. And thyro tends to refer to the thyroid cartilage, although it is used sometimes generally to refer to changes in the shape of the larynx. So the first author to describe 4 different kinds of thyroplasty was Ishiki, one of the great Japanese laryngologists and laryngeal surgeons. The most common one that we use is called the type 1 thyroplasty, and that is used to address a unilateral vocal fold paralysis. So when a patient has a one-sided vocal fold paralysis, generally that's been unrecovered after a year. So we think, although there's interesting data to suggest the time period may be shorter, but historically, after about 9 to 12 months and there's no recovery of function, we think that nerve is not going to come back. And so we consider essentially permanent procedures to support, augment, and boost the left or right side of the larynx. And so that's what a thyroplasty is. It's a procedure to change the shape of the larynx. Now, interestingly, thyroplasty, glottoplasty, so glottis refers to the vocal folds, essentially the level of the vocal folds. I have an increasing number of transgender patients who are interested in pitch raising surgery, and so we do glottoplasties to attempt to shorten the length of their vocal folds to create higher pitch. And then when we do vocal fold injections, sometimes that is referred to as an injection laryngoplasty. So those are all procedures essentially that attempt to change the shape of the larynx to achieve a desired outcome.
Right. And talking about Botox injections,
What
are they? What is in that?
So botulinum toxin is discovered initially in poorly preserved canned goods. I mean, the botulism, it's the same toxin. It is actually a toxin that blocks neuromuscular transition at the level of the muscle. And so it's essentially the same thing that people use for wrinkles in their face, just a slightly different compound. But yeah, it's a toxin that blocks neuromuscular transmission. And so when we do it, and we do it primarily for spasmodic dysphonia, we use a needle that goes in through the cricothyroid membrane at the front of the larynx, through the neck. Sometimes we give a little bit of numbing at the front of the neck just so you feel the needle less, but it goes directly into the thyroid muscle for adductor spasmodic dysphonia. For abductor, we try to get it to the posterior aspect of the larynx. But yeah, we inject that toxin directly into the vocal cord.
And some people have done those Botox injections for muscle tension dysphonia.
Yes, I thought you might go there.
Sorry.
It's no. It's out there. There's less data about it, and I think the effects can be more variable.
Mhm.
And it's a more difficult injection to tolerate because when it's done for muscle tension dysphonia, we typically do it into the supraglottis, which is a more sensitive area.
Mm.
And the idea is to try to relax those structures in a way to chemically denervate them so that there's less squeeze, there's less tension. Yeah, you're right that people do that. I think it's less reliably effective, but it is described. Yeah.
Yeah, I mean, personally, I think I would only have a toxin injected if I absolutely needed it.
Absolutely. I know. The other thing you have to be careful about in the larynx is that dosing. I mean, the muscles of swallowing are right there around the corner. And so if you're not careful about the dosing and the route of administration, people can get really pretty significant dysphagia or issues with swallowing after a bad Botox injection.
Oh,
So
man.
it's worth being careful.
Yeah. And then how about a thyroidectomy?
Yes, so a thyroidectomy is done for a couple of reasons. Most commonly when there's a nodule or certainly a cancer in the thyroid. Now, if there's a nodule that's big and compressing the thyroid or concerning in terms of biopsy, often surgeons will take just one half of the thyroid. If there's a proven cancer in the thyroid, typically they will take the whole thyroid. There's some increasing research into for microthyroid carcinomas, can we take half or whole? But historically, if there's cancer in the thyroid, we take the whole one out, the whole gland out. If it's benign, usually we opt for a partial thyroidectomy because the consequence of thyroidectomy, a total thyroidectomy, is that you no longer have an organ creating thyroid hormone. And thyroid hormone is a really important hormone in the body. It governs a lot of functions, primarily related to metabolism and energy.
Mm-hmm.
And so you need it in your body. So if you undergo a total thyroidectomy, you're basically committed to taking thyroid hormone essentially for the rest of your life.
Right.
So that's why we try to preserve part of the thyroid. So typically thyroid tissue is removed for anatomic disease like nodules or cancer. Sometimes if the thyroid is in such a state of inflammation that it's creating significant toxicity, the thyroid will also be removed completely.
Mm.
But that's basically it. And the consequence of that for singers is just that recurrent laryngeal nerve that I mentioned goes right behind the thyroid.
Mm-hmm.
So that is the nerve that we always talk to patients about being at risk during any thyroid procedure is the recurrent laryngeal nerve. And so when you are a singer facing a thyroid surgery, it's really important that your surgeon knows that you're a singer and that you go to a surgeon who has a lot of experience with thyroid surgery.
Yeah, great. Okay, I'm going to quickly move on to my signature question.
All right.
So I'll just ask
I love
things and you
these.
can answer them quickly.
Okay.
What is some advice you would like to give to an aspiring young performer?
I think there are two kind of big categories. One is I think it takes time. I think this is not necessarily from my perspective as a doctor, but as a pianist. I started playing the piano when I was 5. And I didn't enroll in graduate school until I was 23. So that was 18 years that I had been playing and training and really working hard at technique. And so when I see singers who are 17 years old, just having started voice lessons, and they're frustrated with the fact that they don't know how to sing yet, I think you've got 17 years at least to go.
Mm-hmm.
So I think just the same way, singers start later. And so giving yourself time and patience to build the technique and the coordination, I think is essential. And then the other kind of big piece of advice that we've touched on already, but I really like to drive home is that, yes, this is an artistic endeavor. You are an artist, but you're also an athlete. And so the same way that your peers who are training as sports athletes have to think a lot about rest, recovery, training, nutrition, so do you. And so thinking of the larynx and your voice as not this kind of disembodied artistic thing that you just sort of use metaphor to govern, but really as tissues, muscles that you train, I think will help certainly with vocal health in the long term.
Mm-hmm.
I don't know I'm not a singing teacher, but as a doctor, I think that's one thing that I'd like for singers to hear.
Great. What is your favorite quote?
There's this thing that my dad has been saying to me since I was a little boy, and it seems simple, but it's do your thing. And he would say it to me. I did a lot of piano competitions, And before I would go up, he would just say, do your thing. And that has continued. And even now, as a 37-year-old man, and he's 80, he tells me before a big event, just do your thing. It's a very simple 3 words that captures a lot of what I think about. You train, you work, and then you just go out and you do your thing. I think that applies to voice. I think it applies to surgery. I happen to be a Patriots fan. I know that will drive some listeners away. But the classic Super Bowl where Tom Brady and the Patriots came from behind to beat the Atlanta Falcons from the hugest deficit, at halftime, he said to them, do your job, do your thing. And I think that's great advice.
Yeah, I love that. And I'm sorry, did you just say you're 37 years old?
I'm 37
You
years old.
have done
Yeah.
everything you've done. You have a master's degree from Juilliard, and you are a doctor of laryngology, and you're 37 years old. Do your thing. That's
Thank you.
so impressive.
Thanks. Yeah. I feel privileged and healthy, and God willing, there's a lot of work and life ahead of me. So I'm grateful to be where I am.
Yeah. Who influenced your work the most?
I think it was Margot Garrett, my piano teacher at Juilliard. Not just because of the connections that she made with Stephen Zeitels, but it was actually her that bestowed on me the love of singers and the admiration for what they do. And in a way, helped me understand how to relate to them and how to speak with them and how to nurture them. She is one of the greatest teachers and trainers and lovers of voice. And I think, all things considered, she's probably been the greatest influence on my career.
And what is something new about the voice that you learned this week?
I am privileged to have just come back from the Fall Voice Conference in Dallas. It's a different place every year, but I was very proud. We at NYU, we not only have a clinical enterprise that I'm proud of, but a huge research enterprise that's led primarily by Dr. Ryan Bransky and Dr. Aaron Johnson, my colleagues. And they're doing this really interesting work. I mean, each of them, but Dr. Johnson's lab is looking at the effects of voice training on tissues in the larynx. And specifically, Dr. Schembel, Adriana Schembel, who's a colleague of mine, who's a postdoc, also a clinical speech-language pathologist, presented this really fascinating study about basically the effects of voice training on rat laryngeal muscle tissue. And basically that sometimes people wonder, like when we're doing voice therapy or when you're coaching or when you're learning to sing, is it that you're building the muscles of the larynx? Like, are you building them the same way that you build up your biceps or your quads? And it's not actually. I think it's fascinating. I mean, it's theoretically some of the same skeletal muscle tissue, but when we talk about training a voice and improving the voice, it actually is not always about hypertrophy or growth of the muscle, but more about coordination and mechanics. So I think it's fascinating. Now, we and a couple other centers are starting to really try to zone in on what is this thing that we're doing when we're training a voice.
Yeah, great. What do you wish you would have learned sooner?
I think this will get a little bit kind of personal, but I think probably a lot of listeners will resonate with this. Self-care and self-love. I think a lot of medical training is about self-denial and self-repression, and it has to be in a way because it's intense, but really learning to take care of yourself, learning where the limits are, learning how to say no, and what keeps your tank full. Because if you are operating on empty all the time, you have nothing to give to people. I think it's just been now after years of therapy and reflection. I have a great coach, I have a great therapist, and I have now, admittedly, the kind of space and time as an attending physician to work on that a little bit more. But we talked about this earlier. I think that's very relevant to singers. You're hustling, you're working a job, you're trying to train your voice, but you're not sleeping, you're not eating well, you're not hydrating. And how can you then sort of reach inside yourself and ask this organ to function in a superhuman athletic way? I think that is something that I'm grateful for learning at this stage, but I think the earlier anyone learns it, the better.
Definitely. So, Paul, if the listeners want to get in touch with you, if they want to get a hold of you, how do they do that?
We love to hear from people who love the voice all the time. We have a couple different ways. Our website is nyuvoicecenter.org. very simple, nyuvoicecenter.org. We also have some great social media pages. So we are on Instagram at NYU Voice, and we're also on Facebook at NYU Voice. And we love hearing from you, and we love seeing you. And
Yeah.
come on in.
Great. Thank you so much for coming
Oh,
on today
Christine,
and talking to me.
what
This
a
has been
pleasure.
so much fun and very informative. Thank you so
For
much.
me too. I'm so glad you do this. I'm so grateful to be a part of it.
Thank you all for listening. If you enjoyed this podcast, please tell your colleagues, your students, and your friends. Please subscribe, rate us, and write a review. You can find us on Facebook at Lifelight Massage, and you can also check out my website at lifelightmassage.com. Please join me next week for another wonderful conversation on the visceral voice.